So this first one, actually, okay, this first case, this patient had a procedure a couple of months ago and was still having pain. And this is what their testicles looked like. Oops, sorry. So this was one testicle. This was the right testicle. And you can see that there's this echogenic thing with shadowing. And this was the other testicle. So it had this small little fluid collection in the middle of it. So any guesses on what kind of procedure this patient had? David Fetzer got it. I knew he would get it. This was the patient had a sperm extraction or a micro-TESE procedure. So I'm just going to talk about that for a minute. This is a treatment for Azospermia, which means that basically there's no sperm in the ejaculate. So the way that sperm travels is that it's made in the testicle in the seminiferous tubules, and then it'll go through the epididymis, through the vas deferens, through the seminal vesicles and ejaculatory duct, prostatic urethra, and then through the rest of the urethra. So if there's azospermia, meaning there's no sperm in the ejaculate, there's two possible reasons. One is from obstruction, and the most common cause would be like a vasectomy, which blocks the vas. And if that's the case, that they want to collect some sperm after somebody's had a vasectomy, they can actually basically just go and extract the sperm from the vas deferens itself. And then 60% of the time, there's a production defect, which means that it's not being produced properly within the testicle itself. And so this is where they will do this micro-TESE procedure. So this is a procedure called Micro-TESE or microdissection testicular sperm extraction. What they used to do is basically just open up the testicle and aspirate out sperm. Now what they do is they cut open the tunica, and they'll open up they'll expose the testicle, and then using a microscope, they'll actually look at the seminiferous tubules and look for the ones that look the most engorged. So for example, these ones here are all engorged with sperm. So these would be better candidates than these kind of like these ones here that look more decompressed. And they'll take about 10 seminiferous tubules out and then extract the sperm from them, make sure that they're motile and that they have enough. And then they will, that's it. So in this case, this patient had this microsurgery. One thing that actually I thought David would enjoy is that there was a paper showing that contrast enhanced ultrasound can guide your micro-TESE procedure. This was a paper published that showed that when they used contrast enhanced ultrasound and they went to the areas where the ultrasound showed the highest levels of perfusion, that's where they were able to get the most sperm. Other people have used high transducer linear transducers to try to like look at places that look, the seminiferous tubules look more engorged. So this was my case. And so we basically in the end decided that we thought this fluid collection, afterwards they can get hematomas. So since this was 2 months later, we thought this was probably a liquefied hematoma here. And on this side with the shadowing, we thought there was probably some scarring and calcification of the tunica albuginea from the incision that they make in the mid portion, and that was causing this shadowing here. So any questions?
Very cool.
Okay.